Good morning students. I welcome you all to today's session for the NPTEL online certified course on the topic An Overview on Maternal Health, the Antenatal, Intranatal and Postnatal Care. I am Dr. Barnali Ghosh, an obstetrician and gynecologist working as assistant professor at Viceroy Multispeciality Hospital and Medical Research Center, IIT Kharagpur. Today, we are going to discuss about intrapartum fetal monitoring, and the method or the technique used for this monitoring is cardiotocography, right. So, we have already discussed the antepartum fetal surveillance in our previous class, which includes non-stress test, right, and the amniotic fluid volume, or together we can call as the biophysical profile or the modified biophysical profile. And there we have come across the Manning score, right, the scoring system, and depending upon the score assigned to the fetus in the antepartum period, we assess the fetal well-being. So, what is the difference? It is antenatal, that means the mother is not in labor, right, and it is mostly the antepartum fetal surveillance is done in the later stages of third trimester. Today our topic of discussion is intrapartum, that means when the mother is in labor. The labor onset has already started and we are in active phase of first stage of labor. During this stage, we need to assess or monitor the fetal as well as maternal well-being during the process of labor. So, we have discussed partogram in our previous class, which gives an idea regarding the progress of labor. Also, it includes the cervical dilatation, the gradual cervical increase in cervical dilatation, as well as the fetal descent, right, and mostly it is the monitoring of the active stage of first stage of labor. The delivery or the second stage is not included in the partograph, but we can assess the progress of labor through the active phase. Now, today is the class on CTG, that is cardiotocography, which is also called as continuous electronic fetal monitoring. So, the concepts to be covered in today's class are intrapartum fetal monitoring, that is by cardiotocography, as well as this cardiotocography is actually the monitoring of the fetus as well as the mother. So, the key words are as given, right. So, coming to the discussion proper. So, this is the cardiotocographic machine. So, here you can see this is the pictorial representation of the cardiotocographic machine. So, it has two probes. One is for FHR, fetal heart rate tracing, and this is placed on the uterine fundus, right. So, it is placed on the fundus of the pregnant uterus of the mother, and this probe is actually the toco meaning uterine pressure, right. So, so this is for the pressure, this is for the uterine pressure tracing, right. So, this is on the uterine fundus, and this probe, so this toco is actually involves the uterine pressure, and cardio meaning fetal heart rate. So, this is placed on the FHR tracing in lower uterine segment, right. So, there are two probes and this is present in the hand of the mother. She will press this knob whenever she feels or perceives a fetal movement. So, these three are the probes and that is to be kept over the mother's abdomen. This is on the upper abdomen, this is on the lower abdomen and this is held by the hand of the mother. Now, this is the monitor. This is the monitor. On this we can get the vitals of the mother in the form of pulse, respiratory rate, SpO2, right. Then your temperature, everything, not temperature you have to measure manually, but this is the monitor and this is the paper. This paper will have the tracing, two tracing. Now, this is the FHR tracing, the fetal heart rate tracing and this is the uterine contraction, right. So, this is the whole machine in a nutshell and from this we will get an idea about the FHR pattern, the changes in the fetal heart rate and also in relation to the uterine contraction that are going on during the process of labor. Now, coming to the definition, what is CTG? It is continuous electronic record of the fetal heart rate obtained via an ultrasound transducer placed on the mother's abdomen, right. So, it is a continuous, there is no role of intermittent CTG. If you start a CTG during the process of labor, say there are some indications or abnormalities which have led to continuous fetal heart rate monitoring, you need to continue the monitoring throughout the labor till the delivery, right. So, this is also called as continuous electronic fetal monitoring or CTG. Now, coming to the principle behind it. So, every uterine contraction that occurs during the process of labor is a stress for the fetus, because with every uterine contraction there is decrease in the uteroplacental blood flow, right. So, as the blood flow decreases during the contraction, there is more compromise on the part of the fetus, right. So, there are various mechanisms that are operating on the fetal level to compensate or to survive this stressful condition of labor. So, we can in a nutshell, if you say that fetus has an autonomic nervous system. The autonomic nervous system has two parts, the sympathetic and the parasympathetic. There is always a synchrony between these two systems, the sympathetic nervous system and the parasympathetic nervous system, because the sympathetic will increase the fetal heart rate and parasympathetic will decrease the fetal heart rate. So, system, right. Number 2 are the baroreceptors, which will assess the blood pressure, right. So, in case the arterial blood pressure of the mother increases, it will decrease. If the arterial blood pressure is high, what will happen? The parasympathetic system is activated and that will decrease the fetal heart rate, right. The chemoreceptors, they will sense the acidosis or hypoxia, right. Hypoxia or acidosis will be sensed by the chemoreceptors, right. So, all these features, all this sympathetic system, parasympathetic system, the baroreceptors, the chemoreceptors come into play in the fetus to combat this stressful condition. And also how to overcome for the fetus. As the fetus matures, it can survive these stressful situations because of the presence of hemoglobin F, which has higher affinity for oxygen. So, even in lesser concentration of oxygen, the fetal hemoglobin is able to extract the oxygen from the maternal blood. Also, there may result in anaerobic respiration leading to acidosis. So, lactic acidosis can sometimes result in case of hypoxia in the fetus, right. And number 3 is due to this activation of these chemoreceptors, activation of the baroreceptors or activation of the sympathetic nervous system, it will increase the fetal heart rate by the sympathetic system activity, right. So, all these 3 together is the result of on the fetus during this stressful condition, and all these are plotted on the graph paper in a CTG, and thereby we can assess the fetal condition. Now, coming to the purpose of CTG. Actually, what is CTG doing? It is recording the fetal heart sound or fetal heart rate, to be precise fetal heart rate continuously. So, it helps to prevent unnecessary cesarean section. Number 1, it prevents unnecessary cesarean section, and number 2, it helps to identify any abnormality earlier. We detect or identify any abnormality earlier, and so we can proceed in that direction, or we can intervene timely. So, it helps to monitor the FHR continuously, it helps to check the uterine activity whether it is adequate or not, it helps to detect fetal distress at an earlier stage, and we can gain information about the rate, the fetal heart rate, the rhythm, right, and also about the fetal movement, which is through the handheld probe present with the mother, right. So, all these information we get from a CTG. And now, what is WHO saying, that whether every woman needs to go for a CTG on admission? No, it does not support the use of admission CTG in low risk pregnancy, right. It is not recommended in low risk. In pregnancy which are uncomplicated without any maternal or fetal adversities, we need not go for CTG. In that case, only intermittent auscultation is enough. So, CTG is done only for high risk pregnancies, right. Now, how to categorize? Categorize mother into low risk and high risk, right. So, in case of low risk, I have told that yes, CTG is not required. Here we go for intermittent auscultation. Now, what is this intermittent auscultation? We have already seen that in the first stage we have to monitor FHR, fetal heart rate, in active phase of first stage of labor. At what interval? At an interval of 15 minutes, extremely sorry. So, every 15 minutes you need to monitor the FHR for that mother, right. And say if the mother goes to the second stage of labor, then FHR is to be monitored every 5 minutes. So, this is in case of intermittent auscultation, right. And how intermittent auscultation is done? It can be done by, this is Pinard's fetoscope, any of the 3, you can use the Pinard's fetoscope, you can use the bell of the stethoscope, or you can use the handheld Doppler. With any of the three placed on the mother's abdomen, you hear or you auscultate the fetal heart rate, which is at the interval of 15 minutes in active first stage of labor, and in second stage it has to be monitored every 5 minutes, right. And this monitoring, this FHR should be done at the end of uterine contraction. So, when you palpate a uterine contraction by putting your hand on the mother's abdomen, just at the end of that uterine contraction, you need to monitor the FHR. Why? Because immediately after uterine contraction, you need to assess whether there is fall in fetal heart rate. So, that can be done when fetal heart rate is monitored at the end. So, at the peak of the uterine contraction, at the peak of the uterine contraction, you will not auscultate. You will auscultate after the uterine contraction has ended, right. So, this is about intermittent monitoring, and what is the inference, how to get the inference from this fetal heart rate. And another thing is, you have to auscultate over a period of 1 minute. So, if sometimes we think that yes, we auscultate for 30 seconds or say 15 seconds and multiply it by 4, or auscultate for 30 seconds and then multiply it by 2. No, that is not the rule. You have to auscultate over a period of 1 minute, and then you calculate the FHR, and if it is within 110 to 160 beats per minute, then it is normal. If less than 110 or more than 160, that is fetal bradycardia or tachycardia over a period of 10 minutes. This is also important. Over a period of 10 minutes, it remains as less than 110 or more than 160. Then from intermittent auscultation, we need to go for continuous electronic fetal monitoring or CTG. Any abnormality during the course, we need to convert to continuous fetal heart rate monitoring. So, that was for low risk. Now, coming to the high risk. So, who are the high risk women, right? Who are the high risk? This is what I have already told, that yes, intermittent auscultation should be done for all pregnancies of low risk category, that is without any complication on the part of mother or fetus. But once these happens, when the fetal baseline fetal heart rate is either less than 110 or more than 160, or there you perceive or you auscultate any drop in fetal heart rate after the uterine contraction in the form of deceleration, or any intrapartum risk factors develop on the part of the mother or the fetus, then we convert the intermittent auscultation to continuous electronic fetal monitoring. Now, coming to the indications of CTG. So, these are the high risk group. So, high risk meaning they have some complication in the form of medical or obstetric. So, what are the medical complications in case the mother is having gestational diabetes, right? Gestational diabetes or pre-gestational diabetes, not controlled, right? So, every complication when it is not controlled in pregnancy, hypertension, PIH, BP not controlled. In case of chronic kidney disease, chronic liver disease, these are with some complications in the form, say there is raised creatinine, raised bilirubin, jaundice in the mother, or say any liver cirrhosis, these type of complication on the part of the mother in the form of medical complication. Now, coming to the obstetrical complication, it can be so that it is a post-dated or post-term pregnancy. In case of preterm also, less than 32 weeks, we go for CTG. Previous cesarean section and you are going for a trial of labor by vaginal, you are trying for vaginal birth after cesarean section. IUGR, now we call it as FGR, that is fetal growth retardation in the uterus, right. And in any type of malformation on the part of the fetus, oligohydramnios, very important, right. So, in gross oligohydramnios, we are actually not going for labor or vaginal delivery. In that case, we will directly go for cesarean section. Gross oligohydramnios with say abnormal Doppler, you need to deliver it, expedite the delivery, and you need to go for cesarean section. But mild oligohydramnios, you can go for vaginal delivery, right. But in that case, you need a continuous cardiotocographic monitoring. PROM, PROM meaning pre-labor rupture of membranes, third trimester bleeding in any form in case of abruption, in case of say placenta, not placenta previa, because in that case also you will have to go for cesarean section. So, in case of abruption or oxytocin induction, oxytocin used for induction or augmentation of labor. So, this is important. So, in any labor process or in any mother where you are giving oxytocin infusion, it is mandatory for CTG monitoring for that patient, right. Other complications like preeclampsia, meconium stent liquor, you need to go for continuous CTG trace. So, that was about the mothers who need continuous CTG monitoring. Now, see, this is the CTG machine which I was talking about. It has two probes, right. One probe over the uterine fundus, that will be measuring the uterine pressure, right, and the increase in uterine pressure during uterine contraction, and this probe over the lower uterine segment, it is placed just against the fetal heart, where you auscultate the fetal heart rate by your stethoscope. There you place this probe, and this picks up the fetal heart rate tracing. And another probe is there with the mother. It is mother is asked to press that knob whenever she perceives a fetal movement. And here is the graph coming out, and you need to see the graph over a period of 20 minutes. So, it is coming out continuously, and you can read the fetal heart rate tracing over that period of time, right. So, that is about the method. Now, coming to documentation. So, apart from only fetal heart rate monitoring, you need to document also the patient particulars, right. So, you need to document also the various patient particulars. So, I will just write it down. You need to document the name, age, identification number of the mother, identification number meaning the hospital admission number, and also the pulse, BP of the mother. So, these are the maternal vitals which you document, and very importantly the date and time of CTG tracing. This is very important, from what time the CTG is being traced, right, that has to be written on that paper. And that is all regarding documentation. Apart from these, your heart rate and contraction tracing. And another thing is, in any intervention is done, any intervention meaning in the form of any drugs or epidural analgesia, or say you have gone for a pervaginal examination, or there is change of posture of mother, or say you have done an ARM or the liquor color, if you see, all these are also to be documented on that CTG paper. And in case there is any confusion between the CTG tracing of fetal heart rate or maternal pulse rate. Say you are seeing the fetal heart rate and you are confused whether it is maternal heart pulse or fetal heart rate, then you should always differentiate by a bedside ultrasound. Right. Now coming to the interpretation of CTG, we are actually concerned with the fetal heart rate monitoring, and we have 4 criteria. Number 1 is the fetal heart rate, the baseline fetal heart rate. Number 2 is the baseline fetal heart rate variability. Number 3, the presence of any acceleration in the fetal heart rate in the CTG tracing, or whether there is any presence of deceleration in the fetal heart rate in that tracing, right. So, this is the paper here, this is the tracing for the fetal heart rate, and low down is the tracing for uterine activity, right. So, like this you have the uterine activity tracing, which shows that these are different uterine contractions, and the speed of the paper is 1 centimeter per minute, right. So, these are 1 centimeter square, right. So, this is the speed, this is the paper speed, and this is the fetal heart rate tracing. It will come like this, say like this. So, there will be some accelerations, there may be some decelerations, and these are the fetal heart rate. So, from this you can see what is the baseline fetal heart rate. Baseline fetal heart rate is taken that segment which is devoid of, say, any acceleration or deceleration. I will take this part. So, here we have no acceleration or deceleration. So, here if you draw in the midpoint, so this is the fetal heart rate which corresponds to 120 beats per minute, and also there is variability, beat to beat variability. See, so this single this is 130, 140. So, 1 square is 10. So, see this is going 1 square above and half a square below. So, above it is 10 and below it is 5. So, FHR variability is 10 plus 5 variability, baseline variability. This is 10 plus 5, that is 15 beats per minute, right. This is FHR variability. And number 3 is presence of acceleration, but acceleration we will discuss what is acceleration, what is deceleration, but acceleration may or may not be present in a intrapartum monitoring. I have already spoken about antepartum monitoring, where acceleration was a surest sign of fetal well-being. But here in the intrapartum period, during the process of labor, acceleration may or may not be present, right. But presence of deceleration and what type of deceleration is important to note from this tracing. So, coming to one by one, baseline fetal heart rate. So, baseline fetal heart rate, when it is stable, excluding the acceleration and deceleration, it is the mean level of fetal heart rate, and it has to be determined over a period of 5 to 10 minutes, mostly 10 minutes. It is expressed in the form of beats per minute, right. So, here you can see this is the, so if this segment, if you take this segment, say this is without any acceleration or deceleration. So, I will use, so you take this segment. So, here you see this is the mean baseline, right. Above there is some variation, below there is some variation. So, the mean baseline over this period is of 120 beats per minute. So, here the baseline fetal heart rate is 120 beats per minute. Now, coming to the values, what is the normal value? 110 to 160 beats per minute. What is bradycardia? If it is less than 110, it is bradycardia. Now, you need to know the causes of bradycardia. Say you are getting fetal bradycardia. So, what can be the cause? Number 1 is post-dated pregnancy, because I have told in preterm the sympathetic system is more developed, but in post-term or post-dated there is more maturity of the parasympathetic system which may decrease the fetal heart rate. In case of congenital heart block of the fetus, there can be fetal bradycardia. In case of some drug administration to the mother in the form of benzodiazepine or opioids, and sometimes fetal bradycardia occurs in acute cord compression. So, all these are the causes which needs to be excluded if you get a scenario of fetal bradycardia. Now, coming to fetal tachycardia, which is more than 160 beats per minute. This is fetal tachycardia, and this also should be measured over a period of 10 minutes, both bradycardia. Before you say a case of bradycardia or tachycardia, you need to see over a period of 10 minutes. And what are the causes? This can be fetal cause, which can be in case of fetal infection, in case of preterm. Preterm meaning less than 32 weeks, so more sympathetic activity, more fetal heart rate. It can be due to fetal hypoxia, very important, needs to be excluded, right, in case of fetal tachycardia, or excessive fetal movements. This can be seen by the probe which is placed in the hand of the mother. And some of the maternal causes are there, say in case of maternal fever, in case of maternal anxiety, in case of maternal dehydration, right. All these can lead to maternal tachycardia, which will in turn lead to your fetal tachycardia. In case of hypotension due to any underlying bleeding, right. So, APH or say from placental abruption or placenta previa, it leading to hypotension, leading to maternal tachycardia, leading to fetal tachycardia, chorioamnitis, right. All these infections also increase the fetal heart rate. So, you need to exclude. So, both these are dangerous. It should be in between 110 to 160 beats per minute. Now, coming to baseline variability, I have told that it is in between 5 to 15, right. Now, we say actually less than 5 is reduced variability and more than 25 is excessive variability. So, normal is taken to be 5 to 25, right. In some books it is 5 to 15. But to note why there is variability, because this is a result of the interaction between the nervous system, the sympathetic, the parasympathetic, the chemoreceptors, the baroreceptors and the cardiac receptors. So, all these need to be responsive, and when this fetal variability is present, that means the fetus is in well or good condition, right. So, this is the graph for fetal variability. Normal is 10 to 25, but we take it as 5 to 25. Less than 5 is reduced variability, more than 25 is excess. Both are not normal, right. So, here you can assess every, I told every vertical point square is 10, right. So, I will clear this because, so here you see they have already marked. So, here the variability is 20 because it is enclosing 2 squares, right, 20, here it is 10. So, on a nutshell you can say the variability is 10 to 20 beats per minute, which is normal, right. So, that was regarding fetal baseline variability. Now, coming to acceleration. What is acceleration? Acceleration is increase in fetal heart rate by 15 beats per minute. So, if you take this place which is devoid of any acceleration or deceleration, here the fetal heart rate is 120. Now, in this phase, so it is 120, it has increased and it has gone to 140. So, increase in heart rate has been by 20 beats per minute, right. So, if the increase is more than 15 beats per minute and it stays for 15 seconds, then you consider this to be a acceleration, right. So, this is an acceleration, here this is another acceleration. Why? This is persisting, it is more than 15 seconds. So, it is persisting. So, accelerations I have told that yes, they are very important in the antepartum fetal monitoring. As such, accelerations may or may not be present in a intrapartum fetal monitoring. So, accelerations, what is the definition? It is abrupt increase in fetal heart rate of greater than 15 beats per minute and persisting for 15 seconds. Presence of acceleration is reassuring, right. So, it is reassuring, that meaning that yes, the fetus is in good condition, but to note that absence of acceleration with an otherwise normal CTG is of uncertain significance. That means even if it is absent in a CTG stressing, then also it is, we can say yes, the fetus is in good condition. It is not a necessary to assess the fetal condition in the intrapartum monitoring. So, that was all regarding the up to acceleration. Now, the next part will be the FHR deceleration, and in case of deceleration, if it is present, we need to note whether what is the type of deceleration, that we will discuss in our subsequent class. So, thank you all for your patient hearing. Thank you.